Hello everyone, welcome to our group presentation today. And today's topic is about different kind of personality disorders. As the textbook mentioned, personality disorders occur when personality traits deviate markedly from the expectations of the individual's culture, become rigid and inflexible, contribute to maladaptive patterns of behavior or impairment in functioning, and lead to distress. To be more specific, personality traits are defined as characteristics with which an individual is born or develops early in life. They influence the way in which he or she perceives and relates to the environment and are stable over time. To give you a general picture of personality disorders, the biological and psychological influences would include heredity, temperament, experiential learning, and social interaction. The most common symptoms would be 41% impairment in interpersonal relationship function, 30% dysfunctions in cognition, 18% affect, 6% of impulse control, and children may exhibit difficulties in developing social relationships and school classwork. Adolescents may report being bullied or having odd habits, behaviors, or ideas. Adults may have trouble forming intimate relationships, maintaining or establishing careers, and fulfilling opportunities to mentor future generations. Based on the description of personality traits, personality disorders are identified into 10 specific types or three clusters in the DSM-5. Cluster A, which has odd or eccentric traits that include paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Cluster B, which has dramatic, emotional, or erratic traits that include antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. Cluster C, which has anxious or fearful trait, insecurity, and inadequacy that include avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. The first type of personality disorders is paranoid, is defined as a pattern of distrust and suspiciousness such that others' motives are interpreted as malevolent. Signs and symptoms would be constantly on guard, hypervigilant, and ready for any real or imagined threat, envious and hostile towards others who are highly successful, appear tense and irritable, insensitive to feelings of others, and constantly testing the honesty of others, avoid interactions with others, always feel that others are there to take advantage of them. They do not accept responsibility for their own behaviors and feelings and project this responsibility onto others. Predisposing factors that include a history of childhood trauma, including neglect, may have been subjected to parental antagonism and harassment, hu- humiliation, and betrayal by others. The second type of personality disorders is schizoid, is characterized by emotional detachment, disinterest in close relationships, indifference to praise or criticism, often uncooperative, defined as pervasive pattern of detachment from social relationships and a restricted range of expression of emotions in interpersonal settings. The most signs and symptoms would be cold, aloof, and indifferent to others. They engage more in solitary activities or with animals than with people. They prefer to work in isolation, appear shy, anxious, or uneasy, inappropriately serious about everything, and they unable to experience pleasure, bland affect, and constricted. Predisposing factors. Um, They're influenced by early interactional patterns that the person found to be unsatisfying. Their childhoods would be described as bleak, cold, and notably lacking empathy and nurturing. The third type of personality disorders is schizotypal. It's characterized by odd beliefs leading to interpersonal difficulties, an eccentric appearance, and magical thinking or perceptual distortions that are not clear delusions or hallucinations. It's defined as a pattern of acute discomfort in close relationships, cognitive or perceptual distortions, and eccentricities of behavior. The most signs and symptoms would be aloof and isolated. They behave in a bland and apathetic manner with magical thinking, ideas of reference, illusion. Their speech may be bizarre, often cannot orient the thoughts logically. They are under stress, um, with delusional thoughts, hallucinations, or bizarre behaviors. The predisposing factors may be psychological and environmental factors. Um, it's more common among the first degree relatives of people with schizophrenia than the general population. Fourth type of personality disorder would be antisocial. It is defined as a pattern of disregard for and violation the rights of others, criminality, impulsivity, and a failure to learn from experience. The most signs and symptoms would be ignoring right and wrong. They tell lies to take advantage of others. They not being sensitive to or respectful of others. They manipulate others for personal gain or pleasure. They normally have a sense of superiority and being extremely opinionated. They have problems with the law, including criminal behavior. They've been hostile, aggressive, violent, or threatening to others. They have no guilt about harming others. They do dangerous things with no regard for the safety of self or others. Being irresponsible and failing to fulfill work or financial responsibilities. Predisposing factors. They're often diagnosed of childhood conduct disorder, family history of antisocial personality disorder, or other personality disorders or mental health conditions, experiencing abuse or neglect during their childhood, unstable or violent family life during childhood. It happens more in men than women. Um, Also in lower socioeconomic classes. The fifth personality disorder is borderline, is defined as a pattern of instability in interpersonal relationships, self-image, affects, and marked impulsivity. The most common symptoms would be directly and indirectly self-destructive, lack a clear sense of identity, job losses, educational interruption, marriage breakups, Mood, that would be anger, anxiety, general discontent, guilt, loneliness, frequent mood swing or sadness, thoughts of suicide, predisposing factors, hereditary and stressful childhood. Histrionic personality disorder. It is defined as a pattern of excessive emotionality and attention seeking. In clinical setting, they often demonstrate what our society tends to foster and admire in its members, such as to be well liked, successful, popular, extroverted, attractive, and sociable. They are highly distractible and flighty by nature. Um, they have difficulty paying attention to detail. They portray themselves as carefree and sophisticated on the one hand, and as inhibited and naive on the other. Highly accessible, impressionable, easy influenced by others. They are strongly dependent. Um, inter their interpersonal relationships are fleeting and superficial. The exact cause of histrionic personality disorder is unknown, but predisposing factors can be hereditary, a combination of childhood experiences. Narcissistic personality disorder. It is defined as a pattern of grandiosity, need for admiration, and lack of empathy. In clinical setting, they appear to lack of humility, overly self-centered. They only care for their own desire. They do not see their own behavior as being inappropriate. Um, they view themselves as superior to others. They believe that they are entitled to special rights or privilege. Their mood usually would be optimistic, relaxed, cheerful, and carefree, but easily changed. They would respond with rage, shame, humiliation, or dejection when they don't get their positive feedback or meet their self expectation. Impaired interpersonal relationships, they would choose a partner who would provide them with the praise, positive feedback, and whoever will not ask things in return. Predisposing factors, causes are unknown. Genetics and environment play a big role in this. A parent-child dynamic of excessive pampering or excessive criticism. The parents kind of like expect the child to achieve the things that they did not achieve, possess that which they did not possess, and have a better and easier life than they had. Avoidant personality disorder. It is defined as a pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation. Um, the most signs and symptoms would be timid, withdrawn, perhaps cold and strange. Their speech is slow and constrained with hesitations, fragmentary thought sequences. They feel lonely. They would express feelings of unwanted. They view others as critical, betraying, humiliating. They desire to have close relationships but avoid them because of fear of being rejected. They often show depression, anxiety, and anger at oneself for failing to develop social relations. Predisposing factors. There are no clear causes. Um, it would be a combination of biological, genetic, and psychosocial influences, or childhood trauma or neglect. Dependent personality disorder is characterized by extreme dependency in a close relationship with an urgent search to find a replacement when one relationship ends. It is defined as a pattern of submissive and clinging behavior related to an excessive need to be taken care of. The most signs and symptoms would be lack of self-confidence in their posture, voice, overly generous, thoughtful, underplay their own attractiveness and achievements. They would hide their true feelings. They are often passive and submissive role in relationships. They willing to let others make their important decisions. They feel fearful and vulnerable. They avoid positions of responsibility. Um, they feel low self-worth, easily hurt by criticism and disapproval. Predisposing factors would be genetics or hereditary, nurturing experience from one source, maybe from overprotective parenting. The last type of personality disorders is obsessive compulsive disorder, also called as OCD. It's characterized by indecisiveness and perfectionism with a focus on orderliness and control to the extent that the individual might not be able to accomplish a given task. The most signs and symptoms would be perfectionist, overly disciplined, inflexibility, they fear of making mistakes. So it's very difficult for them to make their own decisions. Um, Very strict adherence to rules, procedures, and rituals. Defense mechanisms, reaction, formation, isolation, intellectualization, rationalization, and undoing. Predisposing factors would be genetics and parenting style, like overly controlled environment. To talk about the defense mechanisms, according to the ATI book, the people who have personality disorders would show splitting, repression, suppression, regression, and undoing. Splitting would be more popular in patients with borderline personality disorder. In the acute mental health setting, it refers to the inability to incorporate positive and negative aspects of oneself or others into a whole image. The patient tends to characterize people as either wholly good or wholly bad. There are a couple of risk factors for um, personality disorders, such as comorbid substance use disorders, history of violent or nonviolent crimes, psychosocial influences such as childhood abuse or trauma, parenting, biological influences such as genetic and biochemical factors. Now we'll talk about the nursing process. On the screen is the DSM-5 diagnostic criteria for antisocial personality disorder. I'm not going to read the whole thing on the screen, but a couple main things that I want to point out that the signs and symptoms may start even before age of 15, but the diagnosis is for individuals at least 18 years, and it's not exclusively during the course of schizophrenia or bipolar disorder. It's interesting that antisocial personality disorder is a common way for individuals to avoid legal consequences. They admit to the healthcare system by court order, most frequently encountered in prisons, in jails, and in rehabilitation services. Nursing diagnosis, we have risk for other directive violence. Um, the body language would show rigid posture, clenching of fists and jaw, hyperactivity, clenching, threatening stances, cruelty to animals, rage reaction, or history of childhood abuse, substance abuse, or violence against others, um, negative role modeling, or inability to tolerance frustration. Defensive coping, um, it includes disregard of society norms and laws, absence of guilty feelings, denial of obvious problems. Um, Next one would be chronic low self-esteem, impaired social interaction, and ineffective health maintenance. For the outcomes, the patient will discuss angry feelings with staff and in group sections. Um, hasn't harmed self of others. They can rechannel hostility into socially acceptable behaviors, follow rules and regulations of the therapy environment. They can verbalize which of his or her behaviors are not acceptable, shows regard for the rights of others, um, does not manipulate others in an attempt to increase feelings of self-worth. For planning and implementation, I picked the risk for other directed violence with short-term goal. Within three days, patient will discuss angry feelings and situation that precipitate hostility. Long-term goal would be patient will not harm others. Interventions, we can accept attitude towards this patient to promote feelings of self-worth. We can do low level of stimuli in the patient's environment, such as low lighting, few people, simple decoration, low noise level to decrease agitation and aggressive behaviors. We can observe their behavior frequently through activities and interactions to ensure their uh, safety, also other people's safety. We can remove all dangerous objects from patient's environment, um, maintain and convey a calm attitude toward patients. We can help them identify the true object of their hostility. This can help unresolved issues so that they may be controlled. For defensive coping, short-term goal is within 24 hours after admission, patient will verbalize understanding of treatment setting rules and regulation and the consequences for violations of them. Long-term goal, by the time of discharge from treatment, patient will be able to cope more adaptive by delaying gratification of own desires and following rules and regulations of the treatment setting. Interventions, we can explain the consequences of violation of the limits, but we gotta be consistent. This may help to decrease repetition of maladaptive behaviors. Provide positive feedback. or reward for acceptable behaviors. This can enhance self-esteem. Also, encourage repetition of desirable behaviors. We can also help the patient to gain insight into their own behaviors. There are a couple questions we can use to ask in evaluation. Has the patient recognized when anger is getting out of control? Did they seek out staff instead of expressing anger in an inappropriate manner? Did they express anger without physical aggression or harm to others? Did they follow rules and regulations of the therapeutic milieu with little or no reminding? Did they express a desire to change? Did they fulfill their daily activities willingly and independently?
Okay, so to switch gears to borderline personality disorder, I just want to get started with talking about some of the DSM 5 diagnostic criteria. These are a set of basic signs and symptoms that clinicians will look for in order to rule out other mental disorders. But usually, in the patient that presents with borderline personality disorder, these are some of the key points that you'll see. So, just to kind of run through them, you'll often see a fear of abandonment, unstable interpersonal relationships, unstable self image, things like low self esteem, perceived low self worth. They'll also engage in impulsive and risky behaviors, um, usually things like excessive spending, gambling, substance abuse, really anything that's really risky. Um, you'll often see these patients do, kind of like what you see with manic patients almost. They also do have recurrent suicidal behavior or self injurious behavior. They will be at higher risk to self harm. They also do experience emotional lability, um, which is essentially like, typical mood swings that really swing from extreme highs and extreme lows. They will often exhibit feelings of emptiness, anger control issues, and you can sometimes see in more severe cases paranoid ideation or dissociation. Okay, so moving on to the nursing process, in terms of borderline personality disorder, when we assess these patients, we'll often see the typical clinical picture of chronic depression, bipolar disorder, an inability to be alone. Again, going back to that fear of abandonment. Um, they interact in a very specific way. Usually, their behavior will seem very manipulative. One key point here is splitting. Um, Oftentimes with these patients, they are unable to see both good and bad at the same time in a person. So to them, you're perceived as either, you know, wholly good or wholly bad. So an example of this would be like if you were working with a patient who was, splitting staff in an inpatient hospital setting, for example, you could come on as the nurse for the night and they would say like, oh, like you are just the meanest nurse ever. The other nurse from before was so nice. She was the best, he was the best, what have you. um, but then let's say the next time you see that patient, it's a completely different picture and they say, oh, you were just like the best nurse. um, the other nurse from the other shift was just awful. So, kind of manipulative behavior like that, just kind of splitting people into this good or bad category, to try to, you know, um, subconsciously manipulate people on their side, I guess. You'll also see self-destructive behaviors, kind of like those risky behaviors that I talked about in the previous slide. And again, you'll see that impulsivity. Um, The impulsiveness also makes it hard for these patients to make decisions. That is another thing that is often seen. So some of the nursing diagnoses that we can see in pertaining to this disorder is an impaired social interaction, evidenced by an inability to form a satisfactory, enduring, intimate relationship with another person, dysfunctional interaction with others, and use of unsuccessful social interaction behaviors. Some short-term goals for a plan of care for a patient that has borderline personality disorder. The patient will remain safe in the milieu and in the therapeutic environment and will contract for safety upon assessment. So again, contracting for safety, like we've discussed earlier on in the class, is basically having a verbal agreement with a patient, basically saying if they feel that they are suicidal or that they want to hurt themselves, they will let you know and you can act accordingly. The patient will identify one maladaptive coping or defense mechanism during their first session of cognitive behavioral therapy. The patient will identify, express, and explore their feelings through introspective reflection by the end of the day. These are all things that can be done on a day-by-day basis for the shorter term. For the longer term, these are often goals that we can try to keep and plan it to be completed by the time of discharge. So just to go through these, the patient will interact appropriately with peers in the therapeutic milieu and in social activities, following expected rules and norms by the time of discharge. The patient will learn to identify and cognitively reframe past behaviors and tendencies that prohibit development of satisfactory interpersonal relationships, again by the time of discharge. And lastly, the patient will employ new positive coping strategies to better function in society, as well as process feelings by the time of discharge. So some nursing interventions that we can kind of expect in a hypothetical plan of care for one of these patients I have written out here, so I'll just kind of go through them. Firstly, explore feelings of abandonment and other similar fears. Help the patient to better understand maladaptive behaviors such as clinging and self-isolation. The rationale would be exploration of these feelings might help the patient come to terms with unresolved issues. So things like introspective journaling, talking things through. This kind of goes along with the approach of cognitive behavioral therapy and psychoanalysis, which I'll touch on in a few. Help the patient identify behaviors and thoughts that impede social relationships and interaction. The patient might not be aware of the consequences of their behaviors or how they may be perceived by others. So in other words, the patient might lack the skills and the self-awareness to kind of navigate social relationships, so they may not know what is causing them to be unsuccessful in that. And lastly, emphasize a therapeutic rapport with the patient without reinforcing dependency. So the key is that knowing that the nurse is available, willing to help, and trustworthy may provide the patient with reinforcement that they are safe and secure. And with anything, any plan of care, the top priority should be safety and security. Reinforcing with your patient that they are in the safest place that they can be, and that you are there to help them, while also keeping the boundaries of that nurse-patient relationship are very important. So after going through your plan of care and going through the previous steps, the last thing that you would want to do would be to evaluate if your plan of care was successful. So some things that you can kind of go through to evaluate your plan. Has the patient been able to seek out staff when they feel the desire to self-harm? Again, going back to that contracting for safety. Have they avoided self-harm? Have they correlated times of desire for self-harm to times of elevation in level of anxiety? Are they able to discuss their feelings with staff? Have they identified the true source of which their anger or anxiety or depression is directed? Are they able to verbalize an understanding of the basis for their anger? That's key. And can they express these feelings appropriately? So moving on to labs, while there is no specific laboratory test that can directly identify um, personality disorders, borderline personality disorder, you can use blood testing to check the serum drug levels for patients that are on specific drugs, either mood stabilizers, antidepressants, antipsychotics. Usually, these are the big three that you would want to keep an eye on. The serum drug level, just to make sure that you're staying in the therapeutic range of that drug and not heading into toxicity or seeing any signs of toxicity. Drugs that are used for mood stabilization, like lithium and valproic acid, you need careful monitoring of serum drug levels because the therapeutic range is very narrow. Another drug that I'm going to talk about in a second, olanzapine, or Zyprexa. It's a second generation atypical antipsychotic. That is a drug that the serum level needs to be checked every few weeks. You also need to do comprehensive metabolic testing and blood testing just to make sure that the patient isn't going to exhibit or isn't experiencing any metabolic changes, which can be an adverse effect, which I will get into in a second. These are some other tests which can be used in adjunct in the patient that presents with a personality disorder. Usually one of the things that you want to look for in these patients is, are they using any substances? So a toxicology screen would be a good option for that. Going back to the impulsive and the risky behaviors that some of these patients will get into, screening for HIV and sexually transmitted diseases is also very important. More so with your borderline personality disorder patients, they're often prone to being more sexually active, taking risks in that sense, having multiple sexual partners. So there is that risk for that. So it's important to make sure that we are screening those patients for that. Okay, so moving on to the treatments of personality disorders. I picked out 3 drugs that I thought would be the most helpful to kind of go over. So in general, pharmacological treatment is more based on the symptoms that manifest with these disorders rather than the disorders themselves. So essentially, you would be treating the symptoms and signs and manifestations that come about with these diseases rather than trying to treat the disorder as a whole, if that makes sense. So if somebody has severe social anxiety, maybe an anxiolytic would help with that. If somebody has extreme mood lability, or they're prone to just these severe mood swings, then a mood stabilizer would be a good option for them. Obviously, with depression, an antidepressant of some form would be good. And if a patient is really having psychotic symptoms, they are struggling with a lot of audiovisual hallucinations, their behavior is just very psychotic, then you can prescribe an antipsychotic for that, or a provider would. But you could expect them to prescribe any one of these for these patients. So, like I said, commonly prescribed medications would include antidepressants, especially selective serotonin reuptake inhibitors, um, beta blockers, which can help with anxiety, antipsychotics, mood stabilizers, anticonvulsants, and anxiolytics. Okay, so the first medication that I want to touch on is sertraline or Zoloft. It's an antidepressant, more specifically a selective serotonin reuptake inhibitor. And sertraline is an antidepressant that's often given to patients with any of the personality disorders within the spectrum who are experiencing some form of more severe depression. Its indications, like I said, are major depression, obsessive compulsive disorder, panic disorder, social anxiety, post traumatic stress disorder, and premenstrual dysphoric disorder, which is PMDD. How sertraline works is it inhibits the reuptake of serotonin at the synapse of the neuron in the junction between two neurons, which increases the amount of available serotonin in nerve synapses. This makes more serotonin available, and kind of helps it stay active in that synapse. It helps elevate the mood and reduce depression. One of the key points about experiencing depression is that these patients will often have a decrease in serotonin, which causes that pervasive depression that kind of won't go away. Some adverse effects to educate your patients on are diarrhea, nausea, xerostomia, dizziness, drowsiness, insomnia, fatigue, and serotonin syndrome. I have that bolded because with anything related to serotonin, especially the reuptake inhibitors or SNRIs too, it's a very dangerous side effect, and as soon as the signs are recognized, patients need to be treated for it because it can be fatal. The signs and symptoms of it are agitation, coma, diarrhea, hallucinations, hyperthermia, hyperreflexia, incoordination, tachycardia, labile blood pressure, which kind of means that it can vary. It can be really high, really low, kind of swing between the two, and vomiting. More severe cases of serotonin syndrome can actually mirror neuroleptic malignant syndrome, which we kind of touched on earlier in the class. But some nursing considerations for this drug would be to screen your patient for a history of bipolar disorder, hypomania, or mania, because antidepressant therapy can promote development of mania in those that are predisposed to it. And like I emphasized before, you want to monitor your patients for signs and symptoms of serotonin syndrome. This can often be seen right after the medication is administered for the first time. Okay, so the next drug that I would like to mention is lamotrigine or Lamictal. It's an anticonvulsant, but it can also function as a mood stabilizer. This is one of the indications for it. So, like I said, the indications are bipolar disorder, acute bipolar major depression, focal onset seizures, trigeminal neuralgia, and mood stabilization. So the way that this drug works is it inhibits the release of the excitatory neurotransmitter glutamate. It also inhibits the voltage-gated sodium channels, which inhibiting both of these things stabilizes the neuronal membrane by inhibiting neuronal overexcitability. So if if a neuron membrane is too positive, that can kind of lead to overexcitability. So if we kind of bring that down a little bit, then that keeps the patient in general from being really, it kind of brings them down. Some adverse effects that you want to look out for in any patients that are on lamotrigine are nausea, chest pain, edema, contact dermatitis, which is kind of an allergic rash, increased libido, weight gain, anorexia, blood dyscrasias, aseptic meningitis, and suicidal ideation. I have that bolded because it is a major adverse effect that you want to keep an eye on. So some considerations for lamotrigine are you want to carefully monitor patients who are using other sodium channel blockers because there is an increased risk for arrhythmias. You want to monitor your patient for suicidal thoughts or ideation. And also, it's rare, but you still kind of want to keep it in the back of your head. You want to look out for seizure activity. The third drug that I want to go over is olanzapine or Zyprexa. It is a second generation antipsychotic or an atypical antipsychotic, and it's an anti-manic drug. It's particularly helpful in patients with more severe borderline personality disorder. Some of the indications are schizophrenia, manic phase of bipolar 1. It's an adjunct to lithium or valproate for mood stabilization. It's also used for the treatment of agitated and aggressive patients that also have psychiatric disorders and for delirium. So olanzapine works by essentially acting as an antagonist to the serotonergic, dopaminergic, and alpha-1 adrenergic receptors. These are all more, I guess, positive neurotransmitters. They're more excitatory. The precise mechanism of action is not known, but it's thought to work through a combined antagonism of dopamine and serotonin type 2 receptors, essentially to kind of bring these patients down when they're psychotic. Some adverse effects that you want to look out for are angioedema, which can present as like a swelling of the lips, the face. You can also see anticholinergic effects. With anticholinergic drugs, you'll see things like dry mouth. You can also see extrapyramidal symptoms, which are things like pill rolling, that smacking of the tongue and the lips, chewing. You'll also see tardive dyskinesia, which is like a twitching of your facial muscles. You can also see sedation, orthostasis, which is a drop in blood pressure as you go from laying down to sitting to standing. Weight gain, hypercholesteremia, and hyperglycemia. These last three are indicative of metabolic disorder or metabolic dysfunction that can occur with this drug. So oftentimes you can see patients that gain a lot of weight on this drug, or they can develop diabetes. So it's really important to keep an eye on these things. Some nursing considerations that are important are it's not for use in elderly patients with dementia-related psychosis because there's an increased risk of death. Like I said before, you want to monitor patients for metabolic changes. So oftentimes providers will order CBCs, daily weights, lipid level checks, and blood glucose checks, just to make sure that nothing is really getting too out of whack. Like I had mentioned, EPS, extrapyramidal symptoms are possible, so you want to keep an eye on that because they can be uncomfortable. It can also cause fetal harm in pregnant women, so that is very important. And I have a note down here, but olanzapine requires serum testing to make sure that the therapeutic range is maintained and toxicity is avoided. Once a patient is started on olanzapine, the serum drug level must be checked every few weeks and then every few months thereafter. Once that patient is immediately administered olanzapine, they need the serum drug level has to be checked pretty quickly. Some other treatments that you'll often see that'll be of benefit to these patients are individual psychotherapy, milieu or group therapy, cognitive behavioral therapy, dialectical behavior therapy, and psychoanalysis. So just to kind of get into each one of these, psychotherapy essentially involves verbal therapist to patient interaction, in which the patient and the therapist develop a trusting relationship to explore the patient's problems. They might go over anything within the patient's current state. It doesn't really focus on past experiences or past life, like early childhood or anything like that. That's more psychoanalysis, which I'll get into in a second. But it mostly will focus on interpersonal relationships, communication, and role relationship. The goal of psychotherapy is to improve interpersonal and social functioning in order to improve and reduce psychiatric manifestations. Milieu therapy, which we kind of went over in class before and we've seen on clinical. The goal of it is to create a supportive and therapeutic environment where the focus is on healing and safety. Within the milieu, patients will learn to cope, interact, and strengthen their interpersonal and relationship skills. You'll often see that it is a bit more structured, so you will see like regular meetings, community events, and therapeutic activities. Like we saw in the behavioral health unit for our clinical, there were community meetings each morning and then group activities for the patients to complete. And that is a key feature of milieu therapy. Cognitive behavioral therapy essentially teaches patients ways to decrease their anxiety, change abnormal or maladaptive behaviors, and help patients learn coping skills. In CBT, patients are taught ways to cognitively reframe their patterns of thoughts and actions. So basically, they will learn ways to approach situations and deal with them in a way that's more beneficial to them. Psychoanalysis is the process of assessing unconscious thoughts and feelings and the potential meanings behind them. This can often delve into things like dreams, intrusive thoughts, past life experiences, early childhood, how was your family life, how was your background, things like that. And it is a longer term treatment, so patients can be in psychoanalytic therapy for up to a few years, if not longer. And dialectical behavior therapy is a cognitive behavioral therapy for patients with personality disorder specifically, or who exhibit self-injurious or self-harm behavior. It focuses on behavior changes as well as acceptance and validation, because, like I said before, a lot of these patients can struggle with self-worth and self-esteem. And all of these definitions that I kind of went through are listed in Chapter 7 and Chapter 5 of the RN Mental Health Nursing ATI book, just if you guys want to go back and kind of review. So, in terms of nurse teaching, one of the key points here is teaching self-care and coping strategies. For patients seeking immediate relief from intense symptoms such as panic or depersonalization, we can teach these patients how to stimulate the parasympathetic nervous system, including doing things like applying ice or ice cold water to the face, or one of my favorite things to do is deep breathing or pace breathing techniques. And what you'll do is you'll inhale through your nose for a set number of seconds, hold your breath, and then slowly exhale through the mouth with pursed lip breathing. And that is really effective in kind of getting people to kind of calm down and ground and center themselves. So that is a very useful skill to teach people. In educational group on clinical, we actually taught patients on one how to do this, and I think it was really helpful. So it's definitely something to keep in the back of your mind if you have patients that are agitated or they're really struggling with acute anxiety. You can teach them this skill, and it does seem to help people. All right, so moving on to NCLEX questions, I have 3, and then I have a case study. This first question is from the Saunders Comprehensive Review for the NCLEX, Chapter 18, if you guys have it, or if you want to go back and reference it at some point. But let's just jump right in. The nurse is caring for a client diagnosed with paranoid personality disorder who is experiencing disturbed thought processes. In formulating a nursing plan of care, which best intervention would the nurse include? And for all of these questions, when I take exams, I like to go in and use the highlighter tool to kind of cue myself in on what I think is key. So I've kind of done that here. But I'll just go through the answers. A, increase socialization of the client with the peers. B, avoid using a whisper voice in front of the client. C, begin to educate the client about social supports in the community. Or D, have the client sign a release of information to appropriate parties for assessment purposes. The answer to this one is B, avoid using a whisper voice in front of the client. Oftentimes when you have a patient that has paranoid personality disorder, or they have some paranoid delusions or things like that, these patients can be very distrustful and suspicious of others. So if you aren't really paying attention to what you're doing and you laugh or you whisper in front of them, it would be counterproductive. They would be very suspicious of you, and that might jeopardize your nurse-patient relationship, and it's not very therapeutic for that patient. And the other options are too intrusive for a client with paranoid personality disorder, paranoid delusions, so you'd want to avoid doing that. The next question comes from the Nurse Labs NCLEX exam, practice exam test bank. I really like Nurse Labs. They have all different kinds of test banks and practice problems and practice questions for every subject, every area that you can think of. So it's a really great tool for getting questions. But this one came from their mental health and personality disorder test bank. So the client says, the FBI is out to get me. The nurse's best response is A, the FBI is not out to catch you. B, I don't believe that. C, I don't know anything about that. You are afraid of being harmed. Or D, what made you think of that? So I'll give you guys a second. And for this one, the answer would be C, I don't know anything about that. Are you afraid of being harmed? This answer presents reality and acknowledges the client's feelings. Interact with clients on the basis of things in the environment. Try to distract the client from their delusions by engaging in reality-based activities. When thinking is focused on things that are actually centered in reality, they'll be less likely to fall into that delusional thinking. It also helps them focus their attention externally. And I have rationales for why the other options would not be correct here. All right, so moving on to the last question. This came directly from our ATI book. The chapter on personality disorders is chapter 16, if you guys want to go back and reference it. A nurse is caring for a client who has borderline personality disorder. The client says, the nurse on the evening shift is always so nice. You are the meanest nurse ever. The nurse should recognize the client's statement as an example of which of the following defense mechanisms: regression, splitting, undoing, or identification. So I'll give you guys a second here. And the correct answer would be B, splitting. I actually talked about this defense mechanism a couple slides back. It's really key to look out for in patients with borderline personality disorder, or patients that can tend to be more manipulative. This is one of the key signs and one of the things that you'll see. So splitting occurs when a person is unable to see both positive and negative qualities at the same time. A client who has borderline personality disorder tends to see a person as all bad one time and all good another time. So they can't see both concurrently. I have rationales for the other defense mechanisms and definitions for them listed here. Alright, so this case study comes from chapter 16 of the ATI book. Excuse me. And it pertains specifically to personality disorders. So in this scenario, a nurse is discussing with a newly licensed nurse the characteristics of personality disorders. So the more experienced nurse says, it is important, Quinn, that you have an understanding of the various characteristics of personality disorders. Tell me more about characteristics each personality disorder has. The newly licensed nurse then says, I need to take a minute to think of them. I'm going to write down the clinical findings for each of them. So if you guys want to do this on your own or take a second to kind of go through it mentally, I'll give you guys a second. But I kind of went through the clinical findings and the criteria for the personality disorders. So those are in the previous slides if you guys want to go through them later on. But so the first point of this case study is to sort the following characteristics into the appropriate personality disorder. The options are antisocial, narcissistic, or borderline. So these are just some things that you can see in all of the personality disorders, but you just kind of want to match these letters to one of these three disorders. And then the second one would be, what interventions should a newly licensed nurse include in a plan of care for a client who has concerns regarding safety? So these are the answers and the rationales. For the first one, antisocial would be F, borderline would be A, C, and D, and narcissistic would be B and E. And just to kind of go over them in a little more detail, so clients who have antisocial personality disorder will often exhibit a sense of entitlement. Patients who have borderline personality disorder, kind of like what I went into before, they will have instability of affect or labile moods, mood swings, splitting behaviors, and fear of abandonment. Clients who have narcissistic personality disorder will exhibit arrogance and a consistent need for admiration. And in terms of the plan of care, safety is always the priority, because some patients who have a personality disorder are at risk for self-injury or violence, whether that's directed at themselves or others. Clients who are diagnosed with borderline personality disorder are at a higher risk for danger to self. And those who are diagnosed with antisocial personality disorder exhibit arrogance and a consistent need for admiration. Okay, so just to wrap up, I was able to find a couple of resources available to patients who have any of the personality disorders. One really good one that is actually right in Bethlehem is the National Alliance on Mental Illness, Lehigh Valley chapter. They offer free mental health education and support groups for family, patients, providers, and more. They also offer acute crisis help, confidential and free crisis counseling, and a helpline. So I have the numbers listed here. Additionally, patients can also text NAMI to 741-741 for round-the-clock crisis counseling through NAMI. And then I have a link to the website here. But it is a really great website because they offer tons of information on mental health diagnoses, what to expect, also things for families that might be struggling with how to care for or how to best support patients that are struggling with these issues. So it is a really good resource to mention to patients if they're, looking for additional support. The second one that I found that I really think would be really beneficial is called Emotions Matter. It's an advocacy group for borderline personality disorder, and it offers peer support groups online and in person, as well as crisis resources. They also have a Facebook group, peer chats, and free education on things like managing relationships, maintaining hope, developing healthy coping habits, and embracing personal strengths. It's a really good resource for people that might not have access to, transport, or they may not be able to physically go to a support group. It's nice because it can be accessed anywhere. Anybody can join the Facebook group and contribute, and it's a nice service because a lot of the support comes from other patients who are also dealing with some of the same problems. So it might be a nice resource for people to get help from people going through the same thing as them. So I have a link for the website here. These both go directly to each of these groups. And that is all. Thank you so much to everybody. I have in each of these slides where I referenced either the textbook or the ATI book. Everything is listed out there. And then I also do have a handout from osmosis.com that goes over each of the clusters of the personality groups. So if there's any other resources or anything that you guys need, please feel free to reach out to us, and thank you so much.